Today we are going to study about diabetes mellitus. It is the most common endocrine disease characterized by hyperglycemia and insulin, which could be resistance, deficiency, or both. So, going on with the classification of the diabetes, it is classified into type 1 and type 2. There are many misnomers which say that it is type Roman numeral 1 and Roman numeral type 2, but now this has been obsolete. This is no longer used, and what is longer now is used is type 1 and type 2. So diabetes mellitus type 1 it has a complete insulin deficiency or a near total insulin deficiency, and further it could be classified into two subtypes, which is type 1A and type 1B. So type 1A is autoimmune destruction of the beta cells. The beta cells are the cells in the pancreas which produce the insulin hormone, and it could be easily remembered by the mnemonic type 1A, so it is autoimmune A. For the second subtype of the type 1 diabetes mellitus, it is an unknown cause for the destruction of the beta cells. Talking about the diabetes mellitus type 2, it is a heterogeneous group characterized by, it has various kind of etiologies in which it could be insulin resistance, or there could be no insulin resistance but there could be impaired insulin secretion, or there could be balanced insulin production and action but increased glucose production. So features of the current diabetes mellitus: the age or the treatment modality is not a criteria for the classification. Terms for like insulin dependent and non-insulin dependent are not used, because sometimes it is also seen that a diabetes type 2 patient also needs an exogenous source of insulin, but hence these kind of terms are no longer used. Type 1 diabetes mellitus occur before the age of 30 years. Autoimmune destruction of beta cells can start at any age. So earlier it was thought, or it was believed, that a type 1 diabetes mellitus occurs only before the age of 30 years or at the time of the birth, but it is not true. Now it has been seen that there are many patients who present with diabetes mellitus type 1 even beyond the age of 30 years. Type 2 diabetes mellitus develops with the increasing age. Yes, this is very true. Type 2 diabetes mellitus is more commonly seen in India because of sedentary lifestyle or increasing age, such kind of factors which will be discussed further in this video. Now some basic points about the insulin metabolism and insulin deficiency. So functions of insulin: it is that decrease the blood glucose levels, increase activity of the glycolytic enzymes, increase glycogen synthesis, increase uptake of the glucose by skeletal and cardiac muscles, decreases the activity of the gluconeogenic enzymes. So what is insulin doing? It is decreasing the activity of the gluconeogenic enzymes. Talking about the lipid metabolism, it increases the lipid synthesis. So now you'll all be very questionable about why does it increase the lipid synthesis. The lipid synthesis it increases is the HDL, or the high density, or the good lipids that we call it in a layman language. So protein metabolism enhance tissue uptake of amino acids and accelerate protein synthesis. The other functions are increase the transmembrane potassium transport. So now it is a very commonly known fact among the medical students who have passed their pharmacological exam. So as long as there is high concentration of insulin in the blood, the potassium levels are low because the potassium escapes as soon as the insulin enters the bloodstream. So it is a common fact that is studied in our second year pharmacology subject. Decreased cyclic AMP levels in the adipose tissue and the liver. Now, if the insulin is deficient, which is commonly seen in diabetes, so insulin deficiency increases the blood glucose level, very known common fact. It decreases the activity of the glycolytic enzymes. Glycogen breakdown into the glucose increases. Decreased glucose transport into the skeletal and the cardiac muscle. Hence, the levels of glucose increases because the uptake is decreased. Decreased glucose transport, increased activity of the gluconeogenic enzymes. So now the gluconeogenic enzymes have increased. They are more and more increasingly making the glucose. Lipolysis, raised plasma, free fatty acids, and ketogenesis. Now, like these kind of complications are very common in diabetic people, that are ketogenesis and the lipolysis, which will be further discussed in detail. Decrease in tissue uptake of the amino acids and reduced protein synthesis. Decrease in movement of the potassium into the cells, increased cyclic AMP levels in the adipose tissue and the liver. So, going further with the etiopathogenesis of the type 1 diabetes mellitus. So, we knew that it is the destruction of the beta cells, which could be autoimmune or the idiopathic. The autoimmune variant was the type 1A, and the idiopathic is type 1B. Okay, so the pathogenesis for the autoimmune disease. So the first is the genetic susceptibility. The most common HLA are the HLA-DR3 and the HLA-DR4. What are the HLA? They are human leukocyte antigens, which commonly causes the antigen and the host reactions in the body, which we also must be knowing about the HLAs, which we have studied more detail in our pathologies in our second prof. So second is the point is the environmental factor. The viral infections may trigger beta cell destruction. So what are the viral infections? Mumps, rubella, coxsackie, and the cytomegalovirus. This is a flow chart. It is a summarized summary of the pathogenesis of the type 1 diabetes mellitus. So we can see it is a genetic susceptibility and the environmental factors. So non-HLA genes or the HLA genes in the viral infections, what are they doing? They're making an immune response which is acting on its own antigens or the beta cells in a ways where there is failure of the self tolerance in the T cells, Th1 cytokinins, CD8 cells or the killer cells, and the autoantibodies. So these are the various pathways by which the body is self-destructing the beta cells. Talking about the pathogenesis of type 2 diabetes, it is a multifactorial disease. So the four major factors, now we saw that the increasing age is one of the factors for acquiring the type 2 diabetes. Second is the obesity, commonly seen in the people having sedentary lifestyles, which is very common in the western part of the world and even among young and adolescents. Ethnicity or a family history are very common. Environmental factors, genetic factors. So this is a flow chart which summarizes all the factors that are related to the development of diabetes mellitus type 2. So genetic factors, diabetic genes, environmental factors, what are the cause due to the metabolic defects, due to which there is an insulin resistance that affects the decrease in the glucose uptake, decreased glycolysis and fatty acid oxidation, and inability to suppress hepatic gluconeogenesis. Okay, and what does this happens is adipokinase and inflammations increases in the body. Now insulin resistance develops in 3 stages, that is beta cell dysfunction, compensatory beta cell hyperplasia. Next, it is the early stage beta cell failure. The second is the late stage beta cell failure. In first stage, where there is compensatory beta cell hyperplasia, the patient is normoglycemic. But as soon as the beta cell starts to fail in the early stage, there is impaired glucose tolerance, or it is known as the pre-diabetic condition. This condition will be further discussed in detail in this video. The last stage in which the total complete failure of the beta cell is achieved, this results in the frank diabetes. Important points about the diabetes. Type 2 diabetes has a concordance of rate 35 to 60% in the monozygotic twins compared to 17 to 30% in diazygotic. If parents are diabetic, then children have a lifetime risk of diabetes. Now, it is not necessary that a parent with a history of diabetes, or both the parents with a history of diabetes, must have a child with a diabetic. So no, the child is exposed to a lifetime risk of diabetes mellitus, but it is not necessary that he will have a diabetes. Type 2 diabetes has no HLA relationship, unlike the type 1 diabetes mellitus, where we had HLA genes which were DR3 and DR4 with no evidence of autoimmune basis. Now the ominous octet. It is a very famous ominous octet in which the pathophysiology of type 2 diabetes mellitus There is multiple drugs in combination may be needed to improve the glucose homeostasis. The treatment should target the underlying pathophysiology. Now, what is happening in a patient with type 2 diabetes? It is not a simple process that the beta cells have been destroyed or the insulin is deficient. No, the insulin is there, the glucose raised levels are there. Now, how to balance them? Now, if you see, the first point is increased hepatic glucose production, decreased incretin effect, decreased insulin secretions, increased glucagon, increased glucose reabsorption. Now, the kidneys, what they're doing is they are restoring the glucose level, they are reabsorbing. Neurotransmitter dysfunction, lipolysis, and decreased glucose uptake. So, it is a multifactorial disease and has a very complex pathophysiology. Talking about pancreatic beta cell mass is intact in type 2 diabetes mellitus in contrast to type 1 diabetes mellitus where the beta cell mass is destroyed. Characteristics of type 2 diabetes mellitus. The first is the insulin resistance, impaired insulin action or secretion, and the third, increased hepatic production of the glucose. Fourth, abnormal fat metabolism. Now these are the four characteristics of a patient in the metabolic characteristics commonly seen in a patient with type 2 diabetes mellitus. There is insulin resistance, there is normal beta cell mass, impaired insulin action. In some cases, there is also impaired insulin secretion. There is increased gluconeogenesis in the liver and abnormal fat metabolism. So let's talk briefly about the insulin resistance. So we are continuously highlighting that the type 2 diabetes mellitus have a condition known as the insulin resistance. So what is that? It is the decrease or the failure of the target tissues to insulin action. Right? The insulin is coming, it is knocking at the door, but the knock is not too loud for the door to be opened. Well, it is an example which could be understood. Obesity and sedentary lifestyle are the main factors for insulin resistance, right? In type 2 diabetes mellitus, central obesity is the very common thing. Now, how is the central obesity more significant in the development of the insulin resistance in a type 2 diabetic mellitus patient? Now, the central adipose tissue is more lipolytic. Now, we see it is more lipolytic than the peripheral sites. So, easily there is more production of there is more lipolysis, decreased lipid, increase in the free fatty acids and decrease in the oxidation of the lipids. So, hence complicating the situation. Insulin resistance is induced by the free fatty acids, which is commonly produced from the central adipose tissue, which is more lipolytic, right? What is it causing? Increased free fatty acid. Now, free fatty acid here is causing the insulin resistance in the type 2 diabetes mellitus. What are the consequences of the insulin resistance? Now, same, going back to the pages that we just learned. Decreased uptake of the glucose, reduced in the glycolysis, and fatty acid oxidation, inability to suppress hepatic gluconeogenesis. Now, what is this abnormalities of insulin secretion? Beta cell dysfunction. Now we are talking about the beta cell dysfunction. Impaired insulin secretion occurs in early course of the type 2 diabetes mellitus. Now the secretion is being impaired, but there is relative insulin deficiency with mainly insulin resistance with hyperglycemia. So there is insulin deficiency, but it is relative. The main cause or the main problem here is the insulin resistance with hyperglycemia. Now, compensatory beta cell hyperplasia. In this the patient is normoglycemic, but what happens is there is long-term demands of the peripheral insulin resistance. Now, due to the insulin resistance, there is increased demand for the insulin for it to act. Now, the beta cells gets increase in the number, there is hyperplasia, increase in insulin secretion. Now, patient then presents with normoglycemic range of the blood sugar. After that, what happens after some years, there is early stage beta cell failure. So, in that, there is impaired glucose tolerance. So, there is a pre-diabetic range. What is that? That is a pre-diabetic state. Okay, it is a pre-diabetic state. Now, after that, in the late stage, there is beta cell failure. decreased insulin secretions, hyperglycemia, and the frank diabetes, full form blown frank diabetes develops. There is increased hepatic production of the glucose, also decreased glucose uptake, abnormal fat metabolism. Now, how is there is an abnormal fat metabolism? There is insulin resistance, there is increased lipolysis from the central fat which is more lipolytic. There is increased free fatty acid, then there is increased insulin resistance, there is increased synthesis of the very low density lipids and the triglycerides in the hepatocytes, deposition of the fat and lipid, there is increase in the central obesity, and the vicious cycle goes on and on. So now deposition of the fat in liver causes non-alcoholic fatty liver disease. Hence, the type 2 diabetes mellitus are more common to the condition known as non-alcoholic fatty liver disease. So now it is a very common question which would be asked in the universities or the prof exams with a marker of 2 or 3 marks. Now, responsible for the dyslipidemia observed in type 2 diabetes mellitus. Hence, there is dyslipidemia, which is increased TGAs, a decreased HDL, which is a good lipids, and increased in the LDL or the VLDL. Seventh is the hyperglycemia or the glucotoxicity, elevated free fatty acids known as the lipotoxicity, and dietary fat, beta cell loss, and deteriorating glucose hemostasis. Now talking about the clinical features of diabetes mellitus. I hope I'm not going too fast for you all to understand the basics or the pathophysiology or the processes happening in the body of a patient with type 1 diabetes mellitus. So, what are the clinical features of the diabetes mellitus, type 1 diabetes? Age. The type 1 diabetes mellitus, age less than 30 years or any age, which is a common fact that we just learned previously. Weight, it is the weight of the patient is normal or the lean, which patient could be thin. Like this is kind of seen in most commonly in patients with type 1 diabetes mellitus. Okay, so weight loss develops over a time of days or the weeks. So weight loss is very frequent or very sudden in a patient with type 1 diabetes mellitus. The classical triad which can never be forgotten, which can never be ignored, is the polyuria, polydipsia, and polyphagia. In severe cases, ketoacidosis. Ketoacidosis is seen. Now the point is the ketoacidosis is more commonly seen only in patients with type 1 diabetes mellitus. Insulin requirement is low in the initial years and increases with the age. And decrease in insulin levels in the plasma level. Decreased C-peptide. Now what is a C-peptide? C-peptide is a factor which is released when the insulin activates in the blood. Now there are 3 chains. There are A, B, and C. Okay, so the C chain is released and the C-peptide levels are low because the insulin levels are decreased. So the insulin levels are decreased, hence the activating insulin level is decreased, hence the C-peptide levels are low. Increased glucagon. The glucagon increases the blood glucose level and suppressible with insulin. Now the glucagon which is getting increased, it is suppressible with insulin, that is exogenous. Now talking about the type 2 diabetes mellitus, age more than 40 years, because we saw it has been seen in people with increasing age. The weight, the patient is normal or obese. Now obese, a person is obese only when he or she has a sedentary lifestyle. So a sedentary lifestyle can occur in any age, my dear children. So due to obesity and sedentary lifestyle, the type 2 diabetes now seen in children and adolescents. So that stereotype of having type 2 diabetes mellitus in the older age is now getting stopped or broken by the new trend that is being seen in children and adolescents, that because of having a sedentary lifestyle or being obese, the children and the young generation is acquiring this disease. So the triad of the diabetes mellitus type 2 is unexplained weight loss, polyuria, and polydipsia. In asymptomatic individuals, diagnosis made right after the routine blood testing or the urine testing. Now these are both are the diagnostic tests. These two testing are very important to diagnose the condition of the type 2 diabetes mellitus. And the urine testing is done to monitor the glycosuria, the presence of the glucose in the urine, and routine blood testing for the hyperglycemia. The type 2 diabetes mellitus patients susceptible to the hyperosmolar hyperglycemic state. Now we have studied that the type 1 diabetes mellitus patient is more prone to the ketogenesis, but here ketoacidosis, must I correct myself? But in the type 2 diabetes mellitus patients are more susceptible to the hyperosmolar hyperglycemic state, which is also known as hyperosmolar non-ketotic coma. So it is a non-ketotic condition but a comatosing in which there is hyperosmolarity that develops inside the body and due to the hyperglycemic state. Talking about some other important topics or the other variants of the diabetes, there is known as the condition LADA. What is LADA? The latent autoimmune diabetes in adults with age more than 30 years. It is an autoimmune type 1 diabetic mellitus variant. It is known as the slow onset type 1 diabetes or the 1.5 diabetes mellitus. So the weight is the patient is non-obese. What is the management? Diet and the oral hypoglycemic agents. Avoid metformins. The metformin is not given for the LADA patients. There is early introduction of the insulin therapy. Okay. So other features are low fasting blood sugar levels and low post-glucagon C-peptide levels. Now talking about another variant of the diabetes mellitus, which is known as the MODY or the maturity onset diabetes of the young. It is non-insulin dependent. Now you must be thinking about why I'm using such terms, but yes, it is known by such terms only. It is non-insulin dependent, monogenic. Now this word is very important if you are studying about the MODY. It is monogenic form of diabetes mellitus, diagnosed at a young age, autosomal dominant. Now since it is a genetic condition, it is or should be studied in the terms of the genetics. So it has an autosomal dominant transmission, mutations in several transcription factors or in glucokinase, insufficient release from the pancreatic beta cells leads to the MODY. What is MODY again? It is the maturity onset diabetes of the young. Okay, so it has a strong family history because it is totally based on genetics. The macrovascular complications seen in earlier generation, insulin resistance is not present unlike type 1 diabetes mellitus or type 2 diabetes mellitus. So this is a table showing a basic difference between the type 1 and type 2 diabetes mellitus as well as the condition known as the MODY. So the type 1 diabetes mellitus frequency, it is very common. The type 2 is strategically increasing because of the sedentary lifestyles. Genetics, it is polygenic and it is monogenic autosomal dominant. Remember, this is a very important question which could be asked in competitive exams as well as the university exams. The family history includes less than 15%, it has more than 50%, and MODY has 100% family history. Ethnicity, it is different races. In MODY, it is Asians, Polynesians, indigenous Australians. The age of onset, type 1 diabetes mellitus, it is throughout childhood or even after 30 years. Type 2 diabetes mellitus in the young adolescents or after 40 years. MODY is a diabetes of the young, so it is less than 25 years. Severity of the onset, acute and severe. It is mild and asymptomatic. The diabetic or ketoacidosis commonly seen in the type 1. In this, it is not present and is absent. Obesity association is more than 90% for the type 2 diabetes mellitus. It could be present, it could be absent in MODY. Acanthosis nigricans, it is a black discoloration of the skin around the neck, or the back of the neck. It is commonly seen in the type 2 diabetes mellitus. It is absent in both MODY and type 1. Autoimmunity, it is positive in type 1 and it is positive in as well MODY. This is a new point of consideration. The pathophysiology includes beta cell destruction, insulin resistance, and relative insulinopenia. And this is beta cell dysfunction entirely. I hope we were able to cover the basics of the diabetes mellitus, both the type 1 and type 2, in this video, and I hope there could be no more doubts. And even if there are doubts, please let me know in the comments below this video, and let me know how I can improve in my next videos, and how I can make you clear about your doubts in the next video. For such important tables, you can go through my video again. This is the most basic and the simplest language that I could have used for you to understand the topic better. Thank you everyone. I hope you enjoyed this video. I hope this was knowledgeable, and moreover, this is only for the knowledge purpose for the M.B.B.S students, and it is not for any kind of misinformation or what. It is for the children who find it difficult to understand some topics in their M.B.B.S journey. Thank you everyone. Keep watching. Please subscribe and like and share. Bye. Meet you in the next video.